Hi, I'm Dr. Randy Martin. We're here at the AATS Mitral Conclave 2017. I'm thrilled to be joined by Marty Leon. Marty, you've been an innovator all your life, in not only procedures but in education. So this is a unique meeting. I think it's great you're here. I want to ask you, what have you learned from the TAVR approach, where you were a pioneer, that you think might help as we move into transcatheter mitral approach?
Well, Randy, that's a great question. I've spent almost 20 years in this whole TAVR space trying to see how we could develop something that would provide patients another alternative, particularly patients that did not have a good surgical option. But what we learned was that a transcatheter device of this magnitude requires more in the way of technical development over a longer period of time. And when you're trying to change the way people think, you need clinical evidence. So we really learned early on that you need high-quality, rigorous clinical trials to help us understand how well the device is performing and what patients we should be treating. And I think those lessons will apply even more so to mitral valve disease.
Marty, where do you think we're going with transcatheter approach to mitral valve, whether it's transeptal, transapical, transfemoral, whether it's clips, rings? You know, where are we going to go with this?
You know, it's interesting. I think for the aortic valve, you can accomplish a lot just being a soloist. To treat the mitral valve, you have to have an orchestra. It's like a symphony.
Right.
So it's multiple different diseases, and you can target different areas of the mitral valve apparatus. So it's not one device, I think, which is going to solve all problems.
Right.
So we're excited about the idea of doing a valve replacement therapy, but it's in the context of recognizing that repair has an important role. So transcatheter repair and replacement, we hope, are going to be complementary and used appropriately in various situations.
Do you see, so if again, you're a futurist, so do you see, where do you think we'll be in 10 years if you looked at mitral valve surgery, repair or replacement, versus transcatheter? I mean, in the aortic, it's beyond what we had envisioned, right? Its majority is going to be transcatheter approach. Where are we going to be in mitral?
Well, we never thought that we would be able to develop a device that would be a workhorse device in garden variety aortic stenosis. We still have to prove that, but I think we're fairly close. So I think we've gone so far that everybody has similar expectations on the mitral side. And I think that may be a little bit unrealistic. Surgery is very good in primary MR, in skilled surgical hands, in appropriate patients. I don't know that we'll ever be able to replicate that, and I don't think we should try to. But I think for all other versions of mitral regurgitation, it's an open field. And I think transcatheter therapy has great potential. And I would predict that in 10 or 15 years, it'll be about 50-50, surgery and transcatheter techniques. And the transcatheter techniques will be split amongst various repair solutions and replacement.
Let me ask you, who's going to be doing these? Okay, so in transcatheter, correct me if I'm wrong, it was primarily the interventionalists, yourselves and your colleagues, the surgeons came along and became very good at it in this country, in Germany. Isn't that correct? In Germany, it was more the surgeons taking the lead?
Well, you know, it's interesting because we've always been aggressive in saying that this heart team has to be more than just in name, and that the surgeons have to become therapists. In fact, we spent a lot of time training surgeons to develop catheter-based skills. My great hope is that the surgical community, frankly, would wake up and embrace transcatheter techniques as part of the armamentarium that they can use to treat patients with mitral valve disease. Whether that happens, I think the jury is still out. But certainly, if they don't, then the interventionalists are going to go right.
Absolutely go by.
There's no question, because transapical as an access site doesn't have very much of a future. So I think everything's going to be done from the venous side, transeptal, because of the safety issues. And I think it really is the sweet spot of interventionalists. So it's going to be imaging folks like you, interventionalists. But I really do hope that surgeons become seminally involved, not just cosmetically involved as an adjunct member of the team, but as part of the operating group, because I think they could contribute a huge amount to the process if they simply dedicated the time and effort to learn certain skills.
Especially in the mitral space. Two more questions. What's going to happen in the tricuspid space?
Oh, that's one of my pet areas right now. We've done about 25 transcatheter cases on the tricuspid side. This is completely open. It's open for several reasons. First, there are no good surgical solutions. Second, medical therapy is terrible. It's diuretics only. And many of these patients, when they're symptomatic, are diuretic unresponsive. So it's completely open. In every study we've ever done, if you have severe TR, it's a negative, independent predictor of outcomes. So we are forging ahead. In fact, the last 2 days I was with a group of people to develop a series of clinical programs in tricuspid disease, transcatheter tricuspid disease. And I think initially it'll be the symptomatic severe TR patients, but ultimately I think it really can be severe TR, but in an early stage of disease, before they get symptomatic, because many of those patients, when they become symptomatic, they're really too far gone. They've lost their right hearts and there's not much to recover. So I really think this will be a two-stage process, but you're going to be surprised. I think the tricuspid is the real sleeper here, and it can actually go beyond the mitral in terms of rapidity of development and clinical need.
It's interesting because I've always contended that tricuspid regurg patients are sort of wallowing over here until they come in with neck veins up to here and their liver's shot. Right. So it really is. Final question, how do you train the valve specialists of the future? If you were a surgeon, if you were a director of surgery at Columbia, how would you train the surgeon, or how do you train the interventionalist? Do we have specialists who have wire skills and surgical skills?
I absolutely believe that that's necessary, just as we do now, even on the interventional side. We have specialists that do chronic total occlusions and advanced coronary work, endovascular work, and then structural work. So you need certain skills. You have to understand the disease, so you've got to be a real student of understanding the pathology and the disease. You've got to understand the imaging. On the structural side, imaging reigns supreme. So echo and CT has to be fundamental, and you have to have catheter skills to be able to manipulate yourself around the heart. But surgeons certainly could learn that, and I would hope that progressive surgical programs will build into the training the imaging pieces and the catheter skill pieces, so that some of the young physicians coming out of surgical programs could really embark upon what to me would be an exciting career.
Absolutely. Listen, you've contributed so much to our knowledge, and I'm thrilled to find you in the mitral space. come on down.
I'm loving it. I'm learning so much.
But you really have, and I appreciate you being here with us. So thanks very much.
It's
And
great
thank
to be
you,
here.
and we've got more for you, so come back.